Our group is T6, and our experiment aims to discover the effects that orthotics, mainly medially wedged orthotics, have on ankle stability. My name's Yamin, and I'll be introducing the topic and explaining our aims. Celia will walk you through our methodology. Chris will explain the data analysis that took place. John will discuss our results, and Jake will give a brief discussion about our findings and give you concluding remarks. The feet and ankles play an important role throughout the gait cycle as they distribute weight and disperse it through this dance phase of walking. As literature suggests, those that experience impaired proprioception in the lower limbs due to injury, age, or genetic predispositions such as flat-footedness may be prone to experiencing instability due to excessive pronation or supination. Pronation is associated with the internal rotation of the leg relative to the foot, and supination, external rotation. Orthotics are an effective tool used during physiotherapy as a non-surgical option, and research by Enge and Perinowaski has revealed that the use of medially wedged orthoses may result in a decreased range of frontal and transverse plane motion at the knee during contact and mid-stance phases of gait. While Nestor, Linden, and Bowker reveal that medially wedged orthoses decreased rear foot pronation and increased the laterally directed ground reaction force during the contact phase, suggesting reduced shock attenuation. Thus, orthotics may reduce muscle activity and support balanced weight distribution and aid in effective and efficient shock absorption during walking or running. We've decided to reference a study that was done by Nestor, Linden, and Bowker, which studied the effect of laterally and medially wedged foot orthoses on kinematics and joint movements of the lower body extremities. They examined 15 subjects who were each asked to perform 10 gait cycles under 3 experimental conditions: with shoes with medially wedged foot orthoses, and also with shoes and laterally wedged foot orthoses. In each experimental condition, subjects walked at a controlled cadence and wore their own footwear, but wore orthoses given by the experimenter. The kinematic and kinetic data from each of the 10 recorded cycles for each subject were averaged for the left and right limbs separately. Data for all subjects were then averaged, and a one-way inertia test was performed to compare the experimental results of the 3 conditions. Results of reduced pronation during the contact phase by medially wedged orthoses were found to reduce shock absorption, and thus potential to decrease strain was found to support a range of literature that suggests that the range of rear foot pronation is reduced during stance while wearing orthoses. The study revealed that the effect of orthoses on the kinematics of the lower extremities were generally minimal, in agreement with LaFortune et al., who described the effects of a similar magnitude during running with a medially wedged shoe. Despite the aforementioned literature, it's important to note that most studies that consider the correction of supination and pronation discuss the impact of wearing ankle-foot orthotics or full-sole functional foot orthotics rather than medially wedged orthotics. Thus, this study aims to ascertain the effect of medially wedged orthotics on ankle stability as characterized by the kinematics and kinetics of the lower limbs during walking. We suspect that there exists, via kinematic linkage of the lower limbs, a functional relationship between ankle eversion and gait characteristics which can be rectified using these orthotics, specifically increased supination during toe-off. This will be experimentally observed by analyzing the temporospatial parameters, kinetics, and kinematics of the lower extremities.
In this experiment, we have 2 subjects who are also our teammates. Both were prescribed medically wedged foot orthotics to prevent the arch from collapsing, and they all conformed to the UNSW ethics protocol. The materials we used are 2 pairs of foot orthotics provided by the subjects, and they all have their own sports shoes. Before we start the motion capture, we measure the anthropometrics of two subjects. The table shown here include age, height, weight, inter-access distance, knee width, ankle width, and leg length. As for marker placement, the precision of marker placement is critical for obtaining accurate results. We attached the lower model markers to our subjects according to Wacom plug-in gait reference guide. We attached right tibia marker and left tibia marker at different positions of shank to distinguish left and right leg. So does the left side marker and the right side marker. The picture here roughly shows the arrangement of markers in our experiment. Our experimental protocol has 4 steps. First, we perform static calibration trial for each subject. They were asked to stand still while the cameras locate each marker. Then Wacom system could check the presence of required marker and label them. After calibration stage, subjects were to work across Kistler force plates while wearing their own shoes without orthotics. They must make sure they are working as normal, and their right foot should hit the force plates. Repeat the trial thrice. Then the subjects were given 5 minutes acclimation period for next motion capture, where the system was dealing with the collected data. The last step, subjects were asked to work across Kistler again with their own foot orthotics in shoes. Also, working normally and hitting force plates with right foot are required. Same with previous process. Repeat 3 times. And here is our OpenSmith animation.
After the files were exported from Vicon, the C3D files were imported into Mocha. The gait cycle was then restricted to a certain time range to reflect one full gait cycle. Certain parameters that we then measured, such as the angle ankles, the motion to the ankle, as well as the ground reaction force, were then exported as a CSV text file. Statistical analysis was then performed using GraphAB Prism 7.04, and multiple t-tests were performed for each parameter for both conditions. The statistically significant result was deemed anything less than 0.05 or 5%, and that was done for each condition, as I said, the orthotics as well as without, and then the planes, the frontal, sagittal, and the transverse were then compared. And the time results were normalized to a % value of the gait cycle, and then the values were filtered for significant p-values, and then these were then displayed in the next few slides as a range. So as you can see, for the ankle angles, in the frontal plane, the 60% gait cycle, there was a significant result that corresponded to the image on the right, which was in line with the initial swing stage of the gait. For the sagittal plane, for the subject 1, it was between 12 and 16 and 95 and 100, and these 2 results corresponded to the loading response and the terminal swing. Lastly, in the transverse plane, there was a very similar pattern seen in the sagittal plane, and between 12 and 16 and 95 and 100% of the gait cycle, there was the loading response and terminal swing seen. In the second subject, there was multiple significant positions seen in the gait cycle. That was between 38 and 57 and 63 and 73, and that corresponded to the terminal stance, the pre-swing and the initial swing. In the sagittal plane, it was between 82 and 100, which corresponded to the mid-swing and the terminal swing. And lastly, in the transverse plane, between 82 and 100, there was significant values corresponding to the mid-swing and terminal, which once again showed a repeated value between the sagittal and transverse. So comparing subject 1 and 2, the overlying areas of the gait that were affected for frontal were initial swing, for sagittal it was terminal swing, and in transverse it was terminal swing. Next we looked at the results for the force, the ground reaction force. and for the frontal plane for subject 1, there were significant differences between the loading response and pre-swing, corresponding to 7 to 8 degrees and 50 to 57% of the gait cycle. For the sagittal, there were significant differences between the initial contact, the loading response, and the initial swing, and this corresponded between 0 and 1%, 13 and 19%, 62 and 64. Lastly, there was difference between the initial contact, loading response, terminal stance, and pre-swing in the transverse plane, and that corresponded to 2, 19, 40 to 41, 54 to 59%. In subject 2, there was slightly varying degrees of similarity. There was differences seen between the initial contact stage in the frontal plane. In the sagittal, it was between the pre-swing between 50 and 62. In the transverse, it was between 31 and 66, corresponding to the terminal stance and the pre-swing. So the overlap in the frontal plane was less obvious compared to the other results. The transverse, for example, showed in both subjects differences in the terminal stance and significantly in the pre-swing as well. Lastly, we looked at the moments, ankle moments for each subject in the frontal, sagittal, and transverse planes, and there was significant differences in the pre-swing for both patients. And that was seen in the frontal plane for subject 1 between 7 and 8 and 12, 16, 49 and 57%, and for the second subject 49 and 66, 77, 99 and 100. And the pre-swing stage was the similar stage that was affected between the both. Unfortunately, there was no significant values between the sagittal and transverse for subject 1, but in the second individual, there was differences in the loading response for the sagittal, and then the terminal stance, the initial swing, and terminal swing were all affected in the transverse plane.
The ankle joint angles in the frontal plane range between 2 degrees of eversion and 9 degrees of inversion. For subjects 1 with a medially wedged orthotics, there's a significant decrease of ankle inversion during 60% of the gait cycle. Meanwhile, subjects 2 experienced an increase of ankle inversion in the beginning of the initial swing. When we look at the kinematics from the sagittal plane, we have insufficient evidence in presenting any significant difference in the dorsiflexion angle during 40% to 60% of the gait cycle. But the maximum dorsiflexion angles have decreased by 1.5 and 2.5 degrees respectively for subjects 1 and 2. For the transverse plane, the orthotics did not have much effect on the ankle rotation, but subject 1's external rotational angle has been increased during the loading response. After putting a medially wedged orthotics, subject 1's ankle eversion moment has been increased from 2.6 up to 5.6 Newton millimeters per kilograms during pre-swing phase. On the other hand, subject 2 has reduced his maximum ankle eversion moments from 3.2 to 2.5 Newtons millimeters per kilograms after putting on the laterally wedged orthotics. Looking from the sagittal plane, there is no significant difference on the graph. One similarity from both graphs was the orthotics reduced the dorsiflexion moment in both cases. From the transverse plane, there is a huge difference in ankle rotational moment for subject 1, where the medially wedged orthotics changed the internal rotational moment to an external rotational moment during the entire stance phase, whereas subject 2 has experienced a decrease of external rotational moment during the terminal stance at 40% to 50% of the gait cycle. Finally, if we look at the vertical ground reaction force, there is a significant decrease of ground reaction force during the pre-swing phase at 50% to 60% of the gait cycle.
Discussion ankle joint angles. So just to clarify, participant 1 was prescribed with medial wedged orthotics, while participant 2 was prescribed with lateral wedge orthotics. So from the results above, the probably most apparent thing is the fact that participant 1's results were much more profound than participant 2's. Now, in saying that though, participant 1 and 2's results supported previous published results, with ankle eversion and inversion reducing respectively. Now, this is expected because this is what the orthotics are designed to do. Additionally, range of rotation decrease. This is also a consequence of the orthotics pretty much impeding the possible ranges of motion. The maximum dorsiflexion angle reduced. A similar observation was made in the reference paper, so this is quite interesting. The reference paper came to the conclusion that this is an artifact of the foot being lifted inside the shoe by the depth of the orthosis, and which alters the sagittal plane angular value of the rear foot complex. Discussion ankle rotation moment. Participant 1 and 2 experienced an increased and decreased inversion moment change respectively. This is in line with the known theory and the reference paper. Participant 1's transition into orthotics saw a rotation moment reversal from internal to external. So this large change in magnitude can probably be attributed to the fact that participant 1's condition was probably overcompensated by the orthotics prescribed. Participant 2's external rotation moment decreased. And finally, we noticed a reduction in dorsiflexion moment across both individuals. The reference paper attributes this to the fact that wedge orthoses alter the stiffness characteristics of the lower limb. This is due to the fact that orthoses reduce the range of rear foot pronation or supination, depending on how they are wedged. Discussion ground reaction force. Peak vertical ground reaction force decreased across both participants, but increased during single limb support mid-stance. Frontal plane ground reaction force decreased for both participants. Sagittal plane ground reaction force initially increased for participant part 1, but was followed by a decrease during loading response. Participant 2's sagittal plane ground reaction force decreased. So these results, by far and large, match reference paper. So bullet point 1 and 2 can be explained for the fact that orthotics correct excessive inversion or eversion, which essentially allows the Achilles tendon to operate more effectively and absorb shock. However, this will occur due to anatomical reasons in the frontal and transversal plane, or the majority of it at least. Now, the sagittal plane results can be explained by the fact that ankle inversion is associated with shock absorption. Limitations. So the patient sample, so we're talking patients of varying gender, height, weight, and an increasing number would be great. Footwear variability, orthotic variability, data acquisition, such as skin movement artifacts, all possible issues. For the future work, so it'd be very interesting to study the kinematics and kinetics associated after prolonged use, either after a couple of hours or even of months after the orthotics have been prescribed and used regularly, and how different types of shoes interact with orthotics would be very interesting. In conclusion, we have reconfirmed the reference paper findings. We have developed an in-depth understanding of how orthotics impact the ankle's kinetics and kinematics. Additionally, we can also distinguish how medial and lateral wedge orthotics differ.